There, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I humbly urge you to sit back and spare me part of your very precious time as I share with you some precious tips which may prove useful in your line of duty. Our first question reads, which of the medications listed below would increase the risks of intracranial hemorrhage, what we abbreviate as ICH? Would it be edoxaban, dipyridamole, fluoxetine, or prasugrel? I'll give you 10 seconds to choose the correct answer. So all the listed drugs increase the risks of ICH. Now, while anticoagulants and antiplatelet agents listed above increase the risk of ICH, numerous studies have demonstrated that selective serotonin reuptake inhibitors also increase the risk of ICH. Now, the SSRIs inhibit the reuptake of serotonin into platelets, and this in turn reduces the release of serotonin after platelet aggregation. Now, we know that serotonin plays a key role in secondary platelet activation and in vasoconstriction to promote hemostasis. Now, there is no clear strategy on how to reverse or eliminate the effects of SSRIs on platelets, given that many SSRIs have very long half-lives and they also have active metabolites. So when they cause ICH, then issues become very, very complicated indeed. Let's move to the next question. And it reads, according to the ACC/AHA guidelines, which of the following is the correct goal LDL level for secondary stroke prevention in patients with a history of multiple major cardiovascular events? Is it an LDL below 100 milligrams per deciliter, below 40, below 70, or is it at least 50% reduction in LDL if greater than 130 milligrams per deciliter? I'll give you 10 seconds to choose the correct answer. Goal of LDL below 70 milligrams per deciliter. Now, patients with atherosclerotic cardiovascular disease, what we abbreviate as ASCVD, maximally tolerated statin therapy should be used to lower the LDL levels by at least 50%. Now, this isn't restricted to only patients with a baseline LDL of levels above 30. Now, the very high risk ASCVD, defined as multiple major ASCVD events or one major event with high risk conditions, LDL level above 70 milligrams per deciliter, should prompt consideration of adding non-statin to statin therapy. Now, such interventions may include the addition of, for example, ezetimibe or what we call a PCSK9 inhibitor, such as alirocumab or evolocumab. Now, there is no current recommendation to target LDL levels to below 40 milligrams per deciliter. So that makes A our correct, sorry, C, our correct answer. D, A, B are wrong options in that case. Let's move to the next slide, please. The question reads, which of the anticonvulsants listed below is or are renally eliminated and therefore need or needs renal dose adjustment in patients with renal impairment? Is it valproic acid, gabapentin, vigabatrin, or lamotrigine? I'll give you 10 seconds to choose the correct answer. Gabapentin it is. Gabapentin is primarily eliminated renally and thus requires renal dose adjustment to avoid accumulation of the drug. Other commonly used anticonvulsants that also require renal dose adjustment may include, for example, Keppra, levetiracetam, and pregabalin. And this is especially relevant if other sedating agents are concomitantly used alongside either levetiracetam, pregabalin, or gabapentin. Now we know that levetiracetam requires dose adjustments once the creatinine clearance becomes less than 80 ml per minute. Now for pregabalin and gabapentin, the doses are adjusted below values of 60 ml per minute. So remember that. Very crucial. Let's move to the next slide. The next question reads, Mr. D.A.M., a 37-year-old male, is brought to your accidental emergency after a road traffic accident. He is neither awake nor alert. He isn't responding to any stimuli or questions. He has a Glasgow Coma Scale score of 3 and he has a 22 gauge peripheral venous catheter in situ. His past medical history is unknown at the moment. He has a systolic blood pressure of 165, diastolic 80, heart rate of 110, a body temperature of 98.6 degrees Fahrenheit, with a height of 70 inches and a weight of 80 kilograms. He is endotracheally intubated and mechanically ventilated at a respiratory rate of 15 breaths per minute, with oxygen saturation 94 on 100% fraction of inspired oxygen. After the trauma team assesses him, a head CT confirms traumatic brain injury. Phenytoin is selected for traumatic brain injury seizure prophylaxis. So my question to you is, what is the most appropriate dose for Mr. D.A.M. to target a total phenytoin level of 20 mics per liter? Note, the C is equal to dose times S divided by volume of distribution, where S is equal to 0.92 for IV route and the volume of distribution is 0.7 liters per kilo. Would it be 1100 milligrams IV? Would it be 1000 milligrams IV? Would it be 1200 milligrams IV? Or would it be 1500 milligrams IV? I'll give you 10 seconds to compute the correct answer. So the correct answer is 1200 milligrams administered IV. Now rearranging the above formula to solve for dose yields a dose of 1219.39 milligrams, which is rounded off as 1200 milligrams. Now just like to remind you that loading dose of phenytoin should be based on empiric weight-based dosing or empiric pharmacokinetic formula principles. Just pay attention to that when you're managing such patients prophylactically. Let's move to the next slide, please. And it says, Mrs. J.J.M., a 37-year-old female patient, has been experiencing mild hip pain, which she grades as a 5 on a scale of 1 to 10. Her past medical history includes paracetamol at a dose of 750 milligrams administered orally every 6 hours with almost no pain relief at all. It's not helping her. She hasn't tried any other analgesics for symptomatic relief of her pain. So my question to you is, what adjustment or adjustments would you propose to her regimen at this time of arthralgia? Would you suggest she continues paracetamol and titrate to the maximum dose? Would you suggest she discontinues paracetamol and initiates naproxen? Would you suggest she discontinues paracetamol and initiates a fixed dose combination of hydrocodone and paracetamol? Or would you suggest she continues paracetamol but reduce the dose to 500 milligrams every 6 hours? I'll give you 10 seconds to choose the correct answer. I would discontinue paracetamol and switch to an NSAID, naproxen. Now at this stage, the paracetamol hasn't been helpful to this patient. Therefore, it would be useful to discontinue it and step up to an NSAID treatment. Now, initiation of the fixed dose combination of hydrocodone and paracetamol wouldn't be an appropriate next step. We know that paracetamol and or an NSAID should be considered first for mild pain like this particular case. It wouldn't be appropriate to have her to continue the use of paracetamol since she's almost taking 3000 milligrams if I approximated well, and exceeding that dose will increase the risks of hepatotoxicity. Now the maximum dose, as we know, is supposed to be 4000 milligrams daily for most patients. Now it wouldn't be appropriate to continue paracetamol at a reduced dose either, since the higher dose doesn't have adequate pain control. Lowering it would worsen the situation. Now patients with mild pain should take oral analgesics first, and they should start with paracetamol and or an NSAID. Now patients with moderate pain should be considered for NSAID or opioid co-formulated with paracetamol combinations as initial treatment therapy. So our best option there would be alternative B. Let's move to the next slide, please. The next question reads, Master WMM, a 14-year-old male, is found to have absence or Paracetamol seizures. My question to you is, which of the medications listed below would be the best first-line option for the treatment of typical absence seizures? Would it be topiramate, carbamazepine, ethosuximide, or oxcarbazepine? I'll give you 10 seconds to choose the correct answer. So ethosuximide, it would be. Absence seizures is the main indications for ethosuximide. Now, Paracetamol or absence seizures is a condition more common in children than in adults. It lasts a few seconds, and I would just like to emphasize that an agent like phenytoin, for example, worsens absence seizures, and it should never be used in such patients. Let's move to the next slide, please. The question reads, Mrs. PMG, a female patient, presents to your clinic for her 30 days post-stroke follow-up clinic appointment. She informs the stroke team she is doing well with her post-stroke rehabilitation. She inquires what she can take for her heartburn, which she experiences daily lately. Currently, she takes lisinopril, amlodipine, pravastatin, dabigatran, and multivitamins as supplementation. So my question to you is, which of the recommendations listed below would you propose to Madam PMG? Is it famotidine 20 milligrams orally once daily to reduce the long-term side effects of a proton pump inhibitor? Or is it 20 milligrams of omeprazole once daily for 12 weeks, followed by reassessment to see whether there is a therapeutic effect or not? Or would it be switching from dabigatran to apixaban for secondary stroke prevention? Or would it be sending her to her primary care physician for an H. pylori test for peptic ulcer disease? I'll give you 10 seconds to choose the correct answer. Would opt to switch from dabigatran to apixaban for secondary stroke prevention. Now we know that both omeprazole and famotidine can be considered, but elimination of the causative agent of the heartburn needs to be addressed first instead of symptomatic relief. Now this lady should visit her primary care physician if the heartburn isn't eliminated by changing from dabigatran anticoagulation to an alternative. It's too soon to refer her to the primary care physician before we intervene. Now, in 4 clinical trials, dyspepsia occurred in 7.5% of patients taking dabigatran compared with 5% taking warfarin. Now, since there are other options available, dabigatran can be replaced with a different anticoagulant to avoid polypharmacy, just to avoid the case of having to give a PPI or any other agent to relieve the heartburn. And it also helps you avoid a prescribing cascade where you'll keep prescribing other drugs whose side effects may need to be sorted out with other drugs. You'd end up with polypharmacy. Let's move to the next slide, please. And the question reads, Mrs. ACL, 77-year-old female, presents to your clinic with a past medical history of hypertension and a case of newly diagnosed atrial fibrillation. Madam ACL doesn't understand why her cardiologist has decided to prescribe what we call a blood thinner for her. So my question to you is, which of the explanations below would you offer Madam ACL? Would you tell her anticoagulation is recommended for all patients with a diagnosis of atrial fibrillation? Or would you choose to tell her anticoagulation is recommended for all patients with at least 2 episodes of atrial fibrillation? Or would you tell her that her age and history of hypertension and atrial fibrillation put her at a risk of a future stroke, and therefore she needs the blood thinner? Or would you tell her that atrial fibrillation greatly increases her risk of developing a deep venous thromboembolism, a DVT? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would tell her her age and her history of hypertension and atrial fibrillation put her at a high risk of a future stroke. Now, I would like to dismiss answer D by commenting that atrial fibrillation has nothing to do with a DVT. So that makes answer D wrong. And anticoagulation can be considered in patients diagnosed with atrial fibrillation, and scoring tools such as the SHA2 DS 2-VAS score, CHADS 2-VAS score, can help guide such decisions based on the risk of developing an ischemic stroke in the next year. Now, patient-specific factors should always be considered in the risk, for example, in the risk to benefit ratio. So you weigh your options whether starting and continuing anticoagulation will cause benefits or increase risks. Now, the number of episodes either perceived by the patient or recorded with a device doesn't weigh heavily on the decision to start or to continue anticoagulation for atrial fibrillation. Now, based on Madam ACL's age, which is above 75, and based on her female gender, based on the diagnosis of an atrial fibrillation and her history of hypertension, in my opinion, her CHADS 2-VAS score is 4, and as 4 of score showed 4.8% stroke risk per year in a study of over 90,000 patients in the Swedish atrial fibrillation cohort study. And I would just like to remind you that a score equal to or above 2 is considered moderate high risk, and anticoagulation should be considered based on guidelines. Now, for patients with an atrial fibrillation diagnosis, anticoagulation versus aspirin therapy should be considered to reduce the risks of ischemic stroke based on patient-specific risk factors. So weigh all your facts before making that decision. Let's move to the next slide, please. It reads, HPB, a patient with atrial fibrillation, is initiated on phenytoin for post-stroke epilepsy. My question to you is, which of the statements below is correct concerning interaction between phenytoin and the novel oral anticoagulants, what we abbreviate as the NOACs, e.g. rivaroxaban, apixaban, and dabigatran? Is it true that phenytoin inhibits metabolism of anticoagulants that utilize the CYP453S system? Or is it true that phenytoin induces the metabolism of anticoagulants that utilize the CYP453S system? Or is it true that phenytoin induces metabolism of anticoagulants that utilize the P-glycoprotein system? Or is it true that both alternatives B and C are correct? I'll give you 10 seconds to choose the correct answer. So both alternatives C and B are correct. Now the first answer is wrong because phenytoin induces both CYP453A4 and the P-glycoprotein enzyme systems. Now phenytoin strongly induces the CYP453A4, which is used by both apixaban and rivaroxaban. Now, phenytoin also induces the P-glycoprotein enzyme system, which is used to metabolize dabigatran, apixaban, and rivaroxaban. So, all those many words justify why D is the correct answer. Let's move to the next slide, please. Question reads, Mr. D.A.M., a 37-year-old male, is brought to your accident and emergency after a road traffic accident. We had seen his case earlier. He is neither awake nor alert. He isn't responding to any questions or stimuli, and he scores a 3 on the GCS scale. He has a 22 gauge peripheral venous catheter in situ, and you do not have a past medical history. His vitals are as shown. He is endotracheally intubated and mechanically ventilated at a respiratory rate of 15 breaths per minute with the oxygen saturation of 94 on a 100% fraction of inspired oxygen. Now, after the trauma team assesses him, a head CT confirms traumatic brain injury. So my question to you is, which of the interventions listed below would be the most appropriate for Mr. DAM now? Would you choose to infuse mannitol at a dose of 1 gram per kilo over 30 minutes? Would you choose to administer fentanyl at a dose of 1 microgram per kilo IV every hour when in pain and for sedation? Or would you opt to infuse 1,000 milligrams of valproic acid twice daily? Or would you opt to administer vecuronium at a dose of 10 milligrams IV stat? I'll give you 10 seconds to choose the correct answer. So I would settle for fentanyl administered at a dose of 1 microgram per kilo IV every hour when necessary for pain and sedation. Now we know that valproic acid isn't appropriate as an anti-epileptic agent for early post-traumatic brain injury seizure prophylaxis due to evidence which suggests harm by this agent. Now, I would like to add that paralysis without sedation isn't appropriate management of mechanical ventilation or elevated intracranial pressure. Now, based on the information provided, there is no clinical or objective evidence to suggest impending herniation or elevated intracranial pressure, and therefore there is, in my opinion, no indication for hyperosmolar therapy at this time using mannitol. That makes alternative A wrong. Now, while Mr. DM may not require sedation due to his current mental status, there is no contraindication to providing analgesia. Now, I would like to add that mechanically ventilated patients should be provided with adequate analgesia and sedation unless the two are contraindicated. And fentanyl is the preferred opioid due to low incidences of vasodilation, fast onset of action, and the ability to rapidly titrate. Now, if mannitol is to be administered, it should be infused with a 0.5 micron inline filter to prevent infusion of precipitates. Remember, it very easily crystallizes even at room temperature. It should be infused over at least 30 minutes since it may cause vasodilation, hypotension, and decrease cerebral perfusion pressure. This would end up complicating issues for your patient. So just a caution. Let's move to the next slide, please. The next question reads, Mrs. MAG, an 86-year-old female, was diagnosed with a primary intracranial hemorrhage, which we abbreviate as ICH, prior to admission at your hospital 4 days ago. Today, she is neurologically back to her baseline function. The CT head results reported as stable 4-day-old intracranial hemorrhage with no signs of ongoing bleeding. The serum creatinine is 1.6, the HB is 11.3, hematocrit at 32.2%. Her platelet count is 233,000 cells per microliter. The INR stands at 1.1. The APTT is 27 seconds, and he has an ideal actual body weight of 65 kilos. She isn't currently taking any antithrombotic medication. So my question to you is, which of the following would be the most appropriate prophylaxis against VTE in the case of Madam MAG now? Is it true that VTE prophylaxis is contraindicated in the case of MAG? Or is it true that you'd consider ambulation, leg intermittent pneumatic compression devices, or would you settle for enoxaparin administered subcutaneously at a dose of 40 milligrams once a day, or would you settle for 2.5 milligrams of fondaparinux administered subcutaneously once daily? I'll give you 10 seconds to choose the correct answer. I would settle for ambulation, leg intermittent pneumatic compression devices. Now, we know that MAG doesn't currently have a contraindication for pharmacologic VTE prophylaxis since there is documentation of cessation of bleeding. She's not bleeding currently. Now, enoxaparin at a dose of 40 milligrams subcutaneously once daily is inappropriate in this particular patient because if you quickly computed her GFR, it would come to something close to 26.4 milliliters per minute. Now, we also know that fondaparinux is contraindicated in patients whose GFR falls below 30 ml per minute. So both C and D are wrong based on her renal function. Then given the available options and the patient being at baseline neurologic function, in my opinion, it's reasonable to continue leg intermittent pneumatic compression devices and attempt to balance by ambulating the patient. I would just like to add that seizure prophylaxis isn't recommended for primary ICH. This differs from secondary ICH, from traumatic brain injury to be specific. So my highly esteemed viewers and listeners, that brings us to the end of part 51 of our pharmacotherapy MCQ series, which majors in neurology. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your kind collaboration. And I would like to say that I look forward to interacting with you in part 42 of our pharmacotherapy MCQ series. Thank you very much for always being there for me.